Uh, Good evening, all. Thank you so much, sir, for this wonderful webinar series on pediatric echocardiography. It's completely privileged to have you on board, sir. I mean, it's a privilege for me to introduce you to the audience. Sir has completed MD in pediatrics and then followed by fellowship in pediatric cardiology. Sir is at this moment Chief Interventional Pediatric Cardiologist at BD Mehta Mahavir Heart Institute, Surat. Sir's primary interest is being fetal echocardiography and transcatheter device closure of VSD. Sir also awarded as a best performer in cardiac catheterization by PCSI in 2012 at Chennai. Sir also has a numerous national and international journals to his credit. Once again, welcome to you, sir, and I would like you to start the session, sir. I'll just stop my screen. Sir.
Good evening, everyone. Thank you for your kind introduction. Is my slide visible to everyone?
Yes, sir, your slide is visible.
Okay. So we will straight away start with our presentation. In today's presentation, what we are going to talk is how clinically we are going to diagnose a child with a suspected heart disease and how to improve our clinical skills and our history taking so that we do not miss a child with a heart disease. So this is the main motive of this lecture today. So we'll start with the lecture. Let us start with the case scenario. We have a 2-month-old baby born by a normal vaginal delivery, came with breathing difficulty and not taking feed. His birth events were normal, and on examination, the child had baseline heart rate of 180. So heart rate is high, tachycardia is there. The respiratory rate is also high, 68 per minute, and there was subcostal retraction. There was no cyanosis, and the pulse volume was good. The precordium was hyperdynamic. If you put your palm on the chest, you can feel that the heart is beating fast. It's called hyperdynamic precordium. The second heart sound was loud, the murmur was present, and the child was very sick looking. So the child was admitted, ABC management was done, oxygen therapy was started, IV fluid started, and chest X-ray was done. So what was seen on chest X-ray? The chest X-ray showed cardiomegaly with congested lungs, and there is evidence of lower respiratory tract infection. So what are we dealing with? We are dealing with a child who is symptomatic at 2 months of age. He's having a murmur. There is no cyanosis, and you have baseline tachycardia, tachypnea, hyperdynamic precordium, mid-diastolic murmur, plethora on X-ray, and cardiomegaly on X-ray. So what are these features suggestive of? These features are suggestive of increased pulmonary blood flow. When the blood flow is increased in the pulmonary circuit, there is volume overload, and hence it will cause tachycardia, tachypnea, hyperdynamic precordium, cardiomegaly on chest X-ray, and plethoric lung fields. So this will be the clinical feature of any child who have features of increased pulmonary blood flow. So we are dealing with a child who is acyanotic. There is no cyanosis, hence acyanotic. Since the child is 2 months of age, it is more likely congenital, and there is murmur, cardiomegaly, so it's likely to be heart disease. And since there is increased pulmonary blood flow, it is all left to right shunt. The commonest left to right shunt presenting at 2 months of age is VSD. So more likely the diagnosis is VSD. So the echo was done, which showed a large perimembranous VSD with severe pulmonary hypertension. This is a usual presentation of a large VSD presenting at 2 months of age with features of increased pulmonary blood flow, volume overload state. So we have another scenario where we have a 3-year-old boy thriving well, asymptomatic, no admissions in hospital, but the murmur was detected in school health checkup. So we have a school health program in Gujarat where the various doctors visits the school and try to find out the heart disease and various other congenital problems. So in that the murmur was detected. On examination, that there was grade 3 by 6 cooing musical murmur in fourth left parasternal space. There was no cyanosis. There are no clinical features of increased pulmonary blood flow, and the chest X-ray is also normal. So what are we dealing with? So we are more likely dealing with a child who is having a physiological murmur. So how should one evaluate a child with suspected heart disease? We will go through all these 4 questions. So when should one suspect a heart disease in children? If you suspect a heart disease in children, whether the heart disease is a congenital one or an acquired one. If it's a congenital heart disease, what is the type of lesion? And further, once you identify the lesion, what is the severity of the lesion? We will try to answer all the 4 questions based on our clinical acumen. So when should one suspect a heart disease? One should suspect a heart disease if the child presents to us with any of the following symptoms, like repeated lower respiratory tract infection. So what is repeated lower respiratory tract infection? If the child has history of admissions for pneumonia for 2 times in a 6-month time frame or 3 times in any time frame with radiological clearance of the chest X-ray, is known as recurrent lower respiratory tract infection. So if you have such history of recurrent lower respiratory tract infection, if you have history of failure to thrive, the mother says the child is feeding well. Even though the child is feeding well, the child is not gaining weight, is failure to thrive. Feeding disturbances like suck, rest, suck cycle. Normally when the child breastfeeds, he continuously feeds. But if the child feeds for some time, comes outside, takes some breathing, and again starts feeding, takes some breathing, if it does sequentially like that, it is known as suck, rest, suck cycle. Sometimes newborn, neonates or infancy, they may have no clear-cut signs of CCF. It is difficult to diagnose CCF in newborn. So only tachycardia could be the feature of CCF in infancy, or sometimes excessive irritability or excessive crying could be the only feature of CCF in infancy age. Other features like breathlessness, cyanosis, spells, convulsions, hypoxic convulsion could be a part of heart disease, and even arrhythmia can cause sudden death. So these are the symptoms based on which one should suspect a heart disease. And once you suspect a heart disease, try to look for these criteria, what we call NADA's criteria. If you have a 1 major or 2 minor, then one should suspect heart disease. In major criteria, if there is grade 3 systolic murmur or a diastolic murmur or a cyanosis or CCF, one should suspect a heart disease. And among minor criteria, at least 2 of the less than grade 3 systolic murmur, abnormal second heart sound, abnormal ECG, abnormal X-ray or blood pressure, one should suspect a heart disease. So once you have suspected based on above signs and symptoms that the child is likely to have heart disease, whether it's a congenital or one, how will you find out? If the symptoms are present from the early childhood, if there is documentation of murmur or abnormal chest X-ray, ECG at birth, one should suspect that the heart disease is likely to be congenital. Central cyanosis and clubbing. Clubbing usually occurs after 6 months of the cyanosis. So when you have clubbing, it means it is long-standing early disease, so more likely to be a congenital. If you have extra cardiac abnormalities, underlying syndrome, then the probability of congenital heart disease is more likely. So various dysmorphic features should suspect that the heart disease which we are suspecting is more likely a part of a syndrome and more likely congenital one. So various heart disease associated with abnormal features like a moon-like phases will be seen in pulmonary stenosis. Polydactyly is a part, maybe seen in aortic stenosis. Elfin phases could be a part of Williams syndrome. where you see supravalvular aortic stenosis or peripheral pulmonary artery stenosis. So when you have Turner syndrome, coarctation is more likely. In Down syndrome, endocardial fusion defect is likely. In Noonan syndrome, Holteram syndrome, we have aortic ASD as a common lesion. In rubella syndrome, PDA and pulmonary stenosis are common. In Marfan syndrome, aortic regurgitation, mitral valve prolapse, aortic dissection are the more common cardiac involvement. So when you suspect a congenital heart disease, what is the type of lesion? How are you going to diagnose it? The congenital heart disease is traditionally classified as acyanotic heart disease and cyanotic heart disease. So among the acyanotic heart disease, further classification is based on pulmonary blood flow. So whether the pulmonary blood flow is increased, normal, or decreased. So based on the pulmonary blood flow, the further classification is made. Among the acyanotic heart disease, when the pulmonary blood flow is increased, it is left to right shunt like ASD, VSD, PDA, AP window. And among the obstructive lesions, we have normal pulmonary blood flow conditions like aortic stenosis, pulmonary stenosis, coarctation of aorta. And among the cyanotic heart disease, further classification is based on pulmonary blood flow increased or decreased. So when you have a decreased pulmonary blood flow, when the blood is not going into the lungs, it is called decreased pulmonary blood flow, and the lesions are tetralogy of Fallot, tricuspid atresia, so right-sided obstructions. And when you have increased pulmonary blood flow, where we have TGA, truncus arteriosus, and TAPVC, these are the mixing lesions where you have cyanosis. At the same time, the pulmonary blood flow is increased. So this is a photograph where we can see where is ASD. So atrial septal defect means defect in the interatrial septum. So when you have a defect in the interatrial septum between the right atrium and the left atrium, it is known as atrial septal defect. In case of atrial septal defect, the blood moves from the left side of the heart to the right side of the heart, and hence excess amount of blood comes into the right side of the heart, as a result of which the right side of the heart will get dilated. In case of ventricular septal defect, there is a defect in the interventricular septum between the right ventricle and the left ventricle. And because of the defect, the blood goes into the lungs, large amount of blood goes into the lung, and hence as a result of which the left side of the heart is dilated. Similarly, in case of patent ductus arteriosus, there is a communication between the aorta and the pulmonary artery, as a result of which the large amount of blood goes into the pulmonary artery and hence into the left side of the heart, and hence the left side of the heart gets volume over. In case of tetralogy of Fallot, as the name suggests, tetra, 4 components. You have pulmonary stenosis, you have ventricular septal defect, you have aortic overriding. Overriding means aorta is above the VSD, or it is dextroposed aorta, and you have right ventricular hypertrophy. So because of the pulmonary stenosis, the large amount of the deoxygenated blood goes via VSD from right side to the left side into the aorta, as a result of which this deoxygenate circulates in the systemic circulation, causing cyanosis. So depending upon the severity of the pulmonary stenosis, the cyanosis can be more or less. In case of transposition of great arteries, as the name suggests, there is switching of the great vessels. Normally, the pulmonary artery arises from the right ventricle and the aorta arises from the left ventricle. But if aorta arises from the right ventricle, the deoxygenated blood will straight away go into the aorta and the systemic circuit, and these kids are symptomatic cyanotic immediately right from the birth. In case of tricuspid atresia, as the name suggests, the tricuspid valve is absent. So the right atrial blood is not able to go into the right ventricle, and hence the right ventricle is hypoplastic, and hence the blood flow to the pulmonary circuit is less, and hence these kids are also having cyanosis and they behave like tetralogy of Fallot. Coarctation of aorta. As the name suggests, coarctation means narrowing. And if there is narrowing at the level of transverse arch and the descending aorta, it is known as coarctation of aorta. Depending upon the severity of the narrowing at this level, the child may present early at birth also, or may present late even in the adulthood. So we have traditionally classified the congenital heart disease as acyanotic heart disease and cyanotic heart disease. And further classification is based on whether the pulmonary blood flow is increased, pulmonary blood flow is normal, or it is decreased. So how are you going to classify the patient based on your clinical evaluation? So how will you define whether cyanotic heart disease or acyanotic heart disease? The acyanotic heart disease and cyanotic heart disease can be defined by physical examination. If the child is cyanotic, you can obviously say that the child is having a cyanotic heart disease. So what is defined as cyanotic heart disease? If the saturation, the cutoff value is 95 on uh, pulse oximeter. If the saturation is more than 94, it is acyanotic heart disease, and if the saturation is less than 94, it is called cyanotic heart disease. Human eye can recognize cyanosis if the saturation is less than 85%. So when you see a child whose saturation is less than 85%, you will be able to clinically diagnose that the child is having cyanotic heart disease. But when the saturation is more than 85 but less than 95, it is difficult for the human eye to diagnose a cyanotic heart disease, in which case one should have pulse oximeter in our OPD. So which area should be looked for? The peripheries can be cold, the limbs can be cold, but the warmer areas like tongue and the palate are the areas where you should look for cyanosis. If the warm area, tongue, is blue or cyanotic, then it is more likely a cyanotic heart disease. So we have classified that the child is having whether cyanotic heart disease or acyanotic heart disease with our clinical skill or with the help of pulse oximeter. The further classification is based on what is the type of pulmonary blood flow. So how are we going to clinically decide whether the pulmonary blood flow is increased, normal, or decreased? So based on history and chest X-ray, we will be able to define whether the pulmonary blood flow is increased, normal, or decreased. So what are the clinical features of increased pulmonary blood flow as seen in case scenario 1? If the child is having repeated chest infection, if the child is having feeding difficulties, suck, rest, suck cycle, hyperdynamic precordium, baseline tachycardia, tachypnea, subcostal retraction, mid-diastolic murmur, excessive sweating, failure to thrive, these all features quantify that the child is having increased pulmonary blood flow. But if there is severe cyanosis and there are no features of CCF, the precordium is quiet, you see clubbing, you see sweating episodes, you see fainting episodes, and even polycythemia. These all features are in favor of decreased pulmonary blood flow. The blood is not able to go into the lungs, and hence as a result of which the child becomes severely cyanotic. And because the less amount of blood goes into the lungs, the less volume of the blood is circulating into the heart, and hence we will not have hyperdynamic precordium, we will have a quiet precordium. So when you put the hand on the chest and try to define whether the heart is beating fast, normal, or less, if you are not able to appreciate much of the cardiac activity and you see that the child is cyanotic, it is more likely a decreased pulmonary blood flow physiology. If you see that the child is having a very fast beating heart and still the child is cyanotic, so it is a increased pulmonary blood physiology with cyanosis like TGA, truncus, TAPVC. And if you put the hand on the precordium with hyperdynamic precordium and acyanotic heart disease, and more likely left to right shunts are the diagnosis. So how will you decide whether the pulmonary blood flow is increased based on chest X-ray? If we divide the chest X-ray in the upper segment and the lower segment, what we will be able to see that in the upper part, on the medial aspects, the venous veins are more concentrated, and on the lateral aspects, the arteries are more concentrated. But in the lower part of the chest X-ray, the arteries are concentrated medially and the veins are concentrated laterally. That's why when we see a patient with pulmonary edema, we see inverted mustache sign like this. Why we see that? Because the pulmonary veins are concentrated here. So if they get congested and dilated, this will be opacified on chest X-ray and will be seen as inverted mustache sign in patients with pulmonary edema. So what are the clinical findings on chest X-ray if the pulmonary blood flow is increased? We see dilated and prominent branch pulmonary arteries because more blood is going into the pulmonary arteries. The right and the left pulmonary artery will get dilated. So that will be seen on X-ray. We will be also be able to see the distal branches in the distal two-thirds of the lung fields. And of course, because large volume of the blood flows into the lungs, there will be cardiomegaly. So this is a chest X-ray where we can obviously see that the heart is enlarged. The CT ratio, the normal CT ratio is 0.5. 0.5 means of this total size, the heart size is 50%. In this particular case, the heart size is up to 70%. So it is definitely a cardiomegaly. We see the main pulmonary artery is also dilated, pulmonary trunk is dilated, and this right-sided opacified structure is right pulmonary artery. This right pulmonary artery is dilated, and what we can see that in the distal two-thirds of the lung fields, we can see the opacity of these vascular channels. So when we see the vascular channels in the distal two-thirds of the lung fields, the right pulmonary artery dilated, the pulmonary trunk dilated, and you see a cardiomegaly, then probably we are dealing with a heart disease which is having increased pulmonary blood flow. So what is features of a decreased pulmonary blood flow? Because the blood is not going into the lungs, the blood will be black. You will not see reticulars, you will not see vascularity, nothing. So it will be oligemic lung fields. The central pulmonary arteries will not be prominent, and hence no extra blood, no volume overload. So you will have a normal size heart. There is a condition where you will have oligemic lung fields, but the central pulmonary arteries are prominent. That is Eisenmenger syndrome. In which case, initially the child had features of increased pulmonary blood flow, but later on with pulmonary vascular obstructive disease setting in, the oligemia had set in, which what we call it as Eisenmenger syndrome. So this is a chest X-ray showing a normal size heart. And what we can see that the right pulmonary artery, which we were able to see over here, and the main pulmonary artery, which we are able to see over here, is not there. And the whole lung is absent of vascularity, what we call it as oligemic lung fields. So when you have oligemic lung fields with normal size heart and you have no prominence of the central pulmonary arteries, it is more likely a heart disease with decreased pulmonary blood flow. So in this particular case scenario, you have no vascularity, the oligemic lung fields, but the right pulmonary artery, the pulmonary trunk is still prominent. So this is a case of Eisenmenger syndrome. So let us have some exercise to judge ourselves whether we are able to diagnose a case of whether it's an increased pulmonary blood flow or a decreased pulmonary blood flow. So we have a cardiomegaly, the pulmonary trunk is dilated, the right pulmonary artery is dilated, and we can see the reticular pattern in the distal two-thirds of the lung field. So it's an increased pulmonary blood flow physiology. In this particular case also you have cardiomegaly, the pulmonary trunk is dilated, the right pulmonary artery is dilated, and you can see the vascularity in the distal two-thirds of the lung field. So increased pulmonary blood flow. Cardiomegaly, increased pulmonary blood flow. Here also we have cardiomegaly with increased pulmonary blood flow physiology. So based on history, clinical symptoms, NADAS criteria, we were able to suspect that the child is having a congenital heart disease. And based on physical examination and pulse oximetry, we were able to confirm whether it's a cyanotic or acyanotic one. And based on history and chest X-ray, the decision was taken regarding the pulmonary blood flow. So we have reached, based on our clinical history and examination, till this point. So whether it's cyanotic or acyanotic, increase or decrease. Now further, is it possible to clinically diagnose these particular conditions? Yes or no? Yes. So once you have reached a diagnosis that we are dealing with an acyanotic heart disease, increased pulmonary blood flow, further diagnosis can be made with the help of additional findings and ECG. So when you are having a diagnosis of increased pulmonary blood flow physiology with acyanotic heart disease, if there is wide and fixed splitting of the second heart sound, and you have right axis deviation with right bundle branch block on ECG, what is right bundle branch on ECG seen as RSR dash in lead V1? It is more likely that we are dealing with atrial septal defect. When you have a murmur with left heart dilatation and features of Q wave and tall R wave in V5 and V6, we are more likely dealing with a ventricular septal defect. So if you have continuous murmur in an acyanotic heart disease, it is more likely a patent ductus arteriosus. So this is an ECG where we can see that the lead 1 is negative and lead AVF is positive. So we are having a right axis deviation, and in lead 1, what we can see is RSR dash pattern. So it is right bundle branch block with right axis deviation, which is a common pattern seen in atrial septal defect. So more likely that the child is going to have atrial septal defect. In this particular case, what we can see over here is lead 1 is positive, lead AVF is positive, so the normal QRS axis. And what we can see here is Q wave in V5, V6 and a tall R wave in V5, V6, which is suggestive that it is a case of VSD. But what we can additional finding which we can see over here is in the mid precordial leads, we see the equiphasic voltages, which is suggestive that we are dealing with a large VSD where we not only have a pressure overload, but we have not only have volume overload, but we have pressure overload also. Among the obstructive lesions, where you don't have any signs of increased pulmonary blood flow, but you have a murmur, you think of obstructive lesion. So if ECG is showing right ventricular hypertrophy, it is more likely to be pulmonary stenosis. If the ECG is showing left ventricular hypertrophy with carotid thrill, it is more likely aortic stenosis. And when you hear a murmur at the back with findings of left ventricular hypertrophy, it is more likely coarctation. Check for the femoral pulses. So what we can see over here, in mild case of a pulmonary stenosis, the ECG will be normal. But if you have a tall R wave in lead V1, then it is suggestive of increase in the severity of pulmonary stenosis. When you have a monophasic R wave in V1, it is suggestive of severe pulmonary stenosis. Similarly, for aortic stenosis, you have deep S wave in V1 and tall R wave in V5, V6. It is suggestive of severe form of aortic stenosis. Now, how will you assess the severity of left to right shunt? In case of small shunt, the precordium will be normal with no cardiomegaly and normal P2. In case of moderate shunt, where the pulmonary blood flow is increased, but not to that extent, we will have hyperdynamic precordium with cardiomegaly with a normal or loud P2, but P2 will be less than A2. In case of large shunt, you will have a hyperdynamic precordium with cardiomegaly and loud and banging P2. This is how you differentiate the type of shunt clinically, whether the precordium is normal, precordium is hyperdynamic. So it will differentiate between small and moderate. So once the precordium is hyperdynamic, try to auscultate P2. If the P2 is loud and banging, it is more likely a large shunt. If the P2 is normal or less than A2, it is more likely a moderate shunt. Similarly, for the obstructive lesion, length of the murmur, if the length is more, the severity is more. Late picking of the murmur, the severity is more. Grade 3, grade 4 murmur, severity is more. And the ECG changes which we have discussed will help us differentiate the severity of the obstructive lesion. Now, once we have come to a diagnosis of cyanotic heart disease with decreased pulmonary blood flow, whether it's a true TOF or something else. So how are we going to diagnose that? That is also based on ECG. Like if you have RS transition from V1 to V2, it is tetralogy of Fallot. But if you cannot see RSRS transition from V1 to V2, it is a top physiology, but not too top. So in this ECG, what we can see there, here is this is lead V1, this is lead V2. So this is R, prominent R wave, and here we have prominent S wave. So there is R to S transition seen in V1 to V2. So when you see this transition from V1 to V2 in a cyanotic heart disease with decreased pulmonary blood flow, then it is tetralogy of Fallot. So when you are suspecting a cyanotic heart disease with increased pulmonary blood flow, you have a hyperdynamic precordium, then the diagnosis likely are TGA, truncus, and TAPs. But how are you further going to differentiate the three? The truncus arteriosus is usually milder form and are diagnosed at a later age, maybe after 1 to 2 months. But in case of TGA, the saturation will be significantly low, maybe around 60, 70. In case of truncus, the saturation will be relatively good, more than 90. And in case of TAPVC, usually it is around 80 to 85, but depending upon the severity of the obstruction, the TAPVC can have even lower saturations. So diagnosis though can be confirmed by the echocardiography, the chest X-ray and ECG plays a vital role in reaching the differential diagnosis in a suspected heart disease. Let us have some few case scenarios. Like this, a 2-year-old child has recurrent wheezing, borderline weight gain, was treated for asthma. And there was suspicion of soft systolic murmur. There was no clubbing, no cyanosis, and mild hyperdynamic precordium. So can we say that define the type of lesion from these findings? Are we dealing with increased pulmonary blood flow physiology? Yes, we have hyperdynamic precordium, recurrent wheezing, and there is a possible soft systolic murmur, minor NADAS criteria meeting. Possibly we need to evaluate the child. So we got the chest X-ray done. The chest X-ray showed cardiomegaly, dilated right pulmonary artery, and main pulmonary trunk. And you have vascularity in the distal two-thirds of the lung field. So when you are seeing this, what does it mean? It means that we are dealing with a acyanotic heart disease with increased pulmonary blood flow. Increased pulmonary blood flow means left-right shunt. So what are the possible left-right shunts that can be present? ASD, VSD, PDA. So we did the ECG. ECG showed negative in V1 and positive in AVF. So it is right axis deviation, and you see RSR dash, so incomplete right bundle branch block. So more likely what we are dealing is an acyanotic heart disease with increased pulmonary blood flow, atrial septal defect. Now coming to one more case scenario, 2-month-old child, acyanotic. And we have grade 4 systolic murmur. Precordium is normal, no hyperdynamic precordium, no cardiomegaly. ECG is also normal. So what is the diagnosis? Grade 4 systolic murmur, NADAS criteria, you need 1. So it is definitely a heart disease. But there is no cardiomegaly. So this child is not having any feature of increased pulmonary blood flow. So when you don't have a feature of increased pulmonary blood flow and grade 4 murmur, so what we are dealing with? We are dealing with a very small shunt or an obstructive lesion. But obstructive lesion will have a heaving type of precordium because of right ventricular hypertrophy or a left ventricular hypertrophy. So more likely we are dealing with a small shunt. If X-ray and ECG is normal, it rules out obstructive lesions also. So more likely shunt is a VSD because grade 4 murmur is present only in VSD. ASD can give maximum up to grade 3 murmur, and PDA will give continuous murmur. Now we have a 6-month-old female with who is asymptomatic and grade 4 murmur in the pulmonary area. But careful examination, the child was cyanotic. The pulse oximeter was showing 88. Precordium is quiet. So when we have a quiet precordium, low saturation, and grade 4 murmur, we are dealing with a heart disease which is cyanotic and precordium is quiet. So it is a decreased pulmonary blood flow. So when we have decreased pulmonary blood flow, so it is TOF or TOF-like physiology. So how will you differentiate between the two? by X-ray, and the X-ray is showing a boot-shaped heart with oligemic lung fields, confirms the diagnosis of TOF or TOF-like physiology, and ECG will showing transition, R wave to S wave transition from V1 to V2. So it is tetralogy of Fallot. So you don't even need echo to confirm the diagnosis. Small surgical details will be picked up on echo. So a cyanotic heart disease with decreased pulmonary blood flow is tetralogy when you have tall R to deep S wave transition from V1 to V2. But if this is not there, it could be any other complex also like VSDPS or DORB-VSD or TGA-VSD, any. So the take-home message. So when you have a hyperdynamic precordium, baseline tachycardia, tachypnea, recurrent lower respiratory tract infection with failure to thrive, and X-ray showing cardiomegaly, dilated pulmonary arteries with increased vascularity in distal two-thirds of the lung fields, it is more likely an increased pulmonary blood flow physiology. And when you have a quiet precordium cyanosis with absence of baseline tachycardia, tachypnea, recurrent infection, and near normal size heart with absent right and main pulmonary artery shadows with oligemic lungs, we are dealing with a decreased pulmonary blood flow physiology. Chest X-ray, ECG are important bedside tool and gives a good insight into the differential diagnosis, and one should do it when you suspect a heart disease. Thank you. Yeah, I would like to welcome the questions if from the audience, if anybody would like to ask the question.
So far, there is no question in chat box. Probably, if somebody would like to unmute themselves, I mean, that is also okay for us.
Yeah. So have we given them authority to unmute and ask the questions directly?
Yes, sir. All the participants can unmute if they would like to.
Okay.
Or else they can raise the hand if they have questions. I can unmute them. So,
Yeah. Dr. Sheetal, are you there?
I don't see Sir Dr. Sheetal Shah in the
Right.
attendees list. Yeah.
Okay. Okay. I think from our side it's fine. Like we will share the whole lecture again. They can see the link on YouTube, and if they have any questions, we are ready, we are welcoming them.
So far, there is no question, sir.
Okay.
Yeah.
Okay, then shall we stop our session right now?
Yeah, I'll stop recording, sir.
Okay.